Hello everyone, and thank you for joining me. My name is Mike Lohmeier, and I am going to be discussing with you some of the basic principles and applications for pre-hospital ultrasound. It's a pleasure for me to be here with you today, and I hope you enjoy this course. Just a little bit about me before we get started. My name is Mike Lohmeier. I am one of the emergency medicine docs over at the University of Wisconsin. I'm also the section chief for EMS at the UW. I'm the medical director for the UW ALS Consortium and also one of the associate EMS fellowship directors. Our objectives for this brief 30-minute talk, we're going to start with just a quick review of some of the basic physics of ultrasound and how it works in the human body. We will talk about some of the point-of-care ultrasound, also known as POCUS, and the implications that it can have for patient care. And then we'll spend a pretty good amount of time talking about some of the opportunities and potential applications for pre-hospital and out-of-hospital use. So before we get started, I do not have any financial disclosures to make, but I do have two pretty significant relationship disclosures that I need to share with you. So the first one is with Madtown Sano. So this is actually a website that's run by Dr. Haney Katab. He's another one of the emergency medicine docs over at the U. He's also one of our core ultrasound faculty. And he's got a really fantastic website that's dedicated to ultrasound education. He puts up cases of the month with the residents and has a lot of interesting findings. He's a fantastic teacher, and I would highly recommend you check out his website. He's also got a Twitter handle that's at MadtownSano, so please go check them out. The second really significant relationship to disclose is with Dr. Sarah Damewood. She's the director of ultrasound education for the University of Wisconsin. She is the fellowship director for ultrasound, and she also does a lot of the education for our emergency medicine residents when it comes to ultrasound education in the ED. The picture down on the lower left is Dr. Damewood. And the reason why our relationship is significant, the presentation that I'm going to give you was actually originally developed by Dr. Damewood and presented previously. I've made a few updates and a few changes to it, but the content is largely hers. So we're going to be spending quite a significant amount of time just talking about point-of-care ultrasound, primarily in emergency medicine and how it gets used. So the term point-of-care ultrasound, or POCUS, as you might hear it commonly referred to, is significant because it is intended to differentiate the ultrasound exams that we do in the ED from the comprehensive ones that get done in the ultrasound suite. The point of care ultrasound is really only intended to answer a binary question. Is there free fluid in the abdomen or not? Is there a pneumothorax that we can see on ultrasound or not? Do we see free fluid around the gallbladder to indicate an acute cholecystitis? It is not comprehensive. We don't do a thorough evaluation, and we don't really look at, all of the detailed structures that they could when they're doing the formal ultrasounds with the trained ultrasonographers. But that's not to say that it's not a hugely useful tool and a valuable skill to have. We can answer a lot of really pertinent clinical questions in a short amount of time without ever having to leave the bedside or leave the trauma bay, which for some of our sickest and most unstable patients is a major advantage for them, because we can make decisions about management in almost real time and help really save patient lives. So why do we need to have point of care ultrasound in the emergency department? Well, really, it's designed for and it specializes in resource limited environments. It also is a specialty tool for patients who, as I was saying, are unstable or aren't able to travel to CT to get their formal ultrasound. We need to do something for them immediately. We need to make a diagnosis and we need to act on some of that information. Some of the places where you'll see ultrasound used extensively are a lot of the developing countries that don't even have access to things like CT and MRI. The nice thing about ultrasound is that it's very compact, it's very portable, it's very reproducible, and you can actually do serial exams and get evolving information in real time. And with this tool, you can diagnose potentially dangerous diagnoses like an ectopic pregnancy or cardiac tamponade. And if they were delayed to get their formal imaging study, obviously that would be catastrophic for those patients. Um, Point of care ultrasound has been a part of the emergency medicine training now for 20 years. Most of the academic emergency departments now have a pretty robust ultrasound program with extensive training, oversight, and quality assurance. I think the thing that stands out the most to me from the beginning of my training to today, I remember going to get the ultrasound machine to go do an ultrasound for a patient, and at that time, it was basically a cart that was probably about the size of a filing cabinet or maybe larger, and stuck to the top of it was a 24-inch cathode ray tube television with these rickety wheels. The thing weighed probably 100 pounds. It was really painful to get around the ED. Now you can see, the device that most of the docs work with are probably a little bit larger than a laptop computer. They're on wheels, they're freely mobile, and there's even some newer ones that you'll see in a little bit here where they just plug into your smartphone or your tablet and you're portable and ready to go. A few caveats, a few things to take into consideration when looking at point of care ultrasound and what you can get from it. Obviously, it's going to be a limited scope because we are only trying to answer yes, no questions with it. Is there an actionable condition or is there not? Is there something else that we need to do? It's more sensitive for ruling in conditions than it is for ruling them out. And the way I describe it to the residents a lot is, if I see gallstones, if I see fluid around the gallbladder on a bedside ultrasound, I believe it's there. If I don't see it, it doesn't mean that it's not there. It just means that I didn't get a good look or I didn't get the good view. It's never going to be, even in the most skilled hands, it's never as good as a CT scan or an MRI. You can only see what's happening where your probe is, and you can't really get a fixed cross section of any of the anatomy at any one time. You're also limited by several factors that I'm going to go into next. So obviously the ultrasound is going to be what we call operator dependent. So it is dependent upon the skill and the practice of the person who's been holding that probe and who's looking at the scan. It does take time to practice and master. It's not just the technical skill of getting the picture, but it's also interpreting what it means and understanding the limitations of ultrasound and correlating your ultrasound findings into the patient care. There are patient and machine factors that limit our ability in point of care ultrasound. Most of the time, we don't have the ability to roll a patient if it's a traumatic case to see how the fluid moves around in their abdomen. And we don't, can't always have them hold their breath, especially in traumatic or severe pain cases. We're going to see a little bit later on, bowel and stomach gas are really difficult to see through with an ultrasound. And often these are overlying areas of interest, right? So if there's a bunch of intestinal gas that's right over the top of the gallbladder, it's going to make it difficult to see and make a call on it. And then obviously, not to anyone's surprise, but as we get bigger and heavier as Americans, difficult body habitus, tight rib spaces can make it really hard to get the depth of penetration on an ultrasound beam. And the statistics would say that even about 15% of the patients that you have a skilled operator and you have ideal circumstances, you're still not going to be able to get the images that you need to interpret. So it's not a perfect test and it's not a fail-safe. Many of the smaller ultrasound machines have limited function because the computer processor is smaller than in the big fancy ones that we roll around on the carts in the ED. So, I've spent probably the last 5 minutes or so talking about the limitations of ultrasound. And so, as Statler and Waldorf would probably say, why do I need to have this? But I think the long and the short of it is that ultrasound does save lives by being able to identify there's free fluid in the abdomen. I can get my trauma surgeon or my emergency general surgeon to take them to the operating room expeditiously for damage control. I can look for that ruptured ectopic pregnancy. I can see there is a tension pneumothorax on ultrasound and diagnose it, so I can put that chest tube in. I can actually do a window and see that the person has a big pericardial effusion. We can drain it. So we can intervene on many conditions and save lives in real time, right in the trauma bay. As my grandfather always used to say to me, the secret to technology is finding the right wrench to pound in the correct screw. Technology is it's something that's a very, very powerful tool. It keeps moving. It never stops. But if you don't know what you're doing, you can look pretty clumsy and pretty silly. So what we're going to do is go through just a couple of the nuts and bolts of how ultrasound works. And hopefully you'll also agree that it's a helpful tool and it's worth learning the physics behind it. So what is ultrasound? So the answer is right there in the name. Ultrasound is a sound wave that transmits through something, and it's a high frequency that's beyond what the human ear can hear. And I think that there's many examples of this that occur in nature or things that you're probably familiar with. So bats use sonar to fly at night, and basically they emit sounds, and when they bounce back, it gives them a reading on how far objects are from them, and so they can try and navigate in the dark. Dolphins will use this underwater with fish, and so that's how they'll hunt and they'll find them. They make the clicking and the noises so that it bounces sounds back to them. They can figure out, where their prey is and where their next meal is going to be. And then probably the one that everyone's most familiar with are the uses of ultrasound and sonar on the submarines. So we will use sound waves. Basically, they ping a sound out and then wait and listen for it to reflect back. And the time that it takes for it to come back can make basically a picture and give you an idea of how far away objects are from you. So it's the same principle with the ultrasound probes that we use in the hospital and in the emergency departments. For each of these probes, there's basically a set of crystals that are in the head of the probe. They use electrical impulses from the machine that vibrate the crystals to create a sound wave, which then gets sent out from the probe into the body. That wave then enters the tissues and echoes back to the probe, and the ultrasound machine uses a processor to take that information and basically make a two-dimensional picture out of it. So let's talk a little bit about what the individual probes are and what they look like. So this first one is the high frequency linear probe. This is the probe that we use pretty commonly for superficial applications like starting an IV or starting a central line for a patient. It has the highest frequency of sound at 10 megahertz. But the trade-off is that the better the picture is, the shallower the depth that you can get a good and accurate picture. So the high frequency linear probe is only good for a depth of about 6 centimeters, give or take. And this schematic here in the lower left-hand corner shows how the crystals are all lined up so that it shoots straight out and comes straight back to the probe and makes a picture that way. The curvilinear probe is the next one that you've probably seen, and this is the one that we probably use the most often. It's the most utilitarian probe in the emergency department. This is the one that we use for the fast exams that we do during trauma. It has the lowest frequency of vibration at 2 megahertz, but because of that, it's able to penetrate deeper. It'll go to a depth of about 30 centimeters. The resolution is not as good as the high frequency probe. And that's because of again, the trade-off, the depth for the quality. The schematic here shows how that ultrasound beam shoots them out straight into the tissue. They're equally spaced out from the curved footprint, but then it's able to collect them back on a curved shape. And then the last one that I'll talk about is the phased array probe. This is the one with the smallest footprint. It's a very special probe. Unlike the linear and the curvilinear probe, it has a beam that spreads out in a phased pattern. It splays outward, and it's helpful in maneuvering in between tight spaces like ribs. It's got a poor near field resolution because the beam is diverging out, but it gets better about midway down. And its frequency is about 5 megahertz, and the depth for this one is about 21 centimeters. Most commonly, we'll use this one for cardiac ultrasound, but we can do it for some abdominal scans and chest scans as well. These are some of the new and evolving probes that are out there. And I think about the evolution of these products. It's a lot like when cell phones first came out with digital cameras in them. The quality was rough at the beginning, but with every other product that's worthwhile and interesting to people, they keep dialing in the technology a little bit more. Probably the two that you have seen the most frequently out there are the butterfly probe, which is this one here, the black one with the butterfly on it. That one will plug directly into an iPhone or an iPad, and you can make a picture right off of that. This is the Wave, which is a completely wireless ultrasound probe that also works with a smartphone. This GE probe is pretty interesting because it's got two probes on either side of it, depending on how big of a footprint you have or what your use is. And then the one that you probably have seen previously is the Philips Lumify. That device is actually being used by our med flight doctors on the helicopter now. A little bit more about specifics. So the orientation is important. So it's not enough to just put a probe on somebody's abdomen and take a look at a picture and say, I think I know what I see. You want to make sure that you understand the orientation of your probe and what you're exactly looking at. And in order to do this, we have a standardized approach for how we achieve those images. So this is a view of the right upper quadrant of somebody's abdomen, so right where the liver and the kidney interface. And this gray structure here is the liver, and then right behind it here is the right kidney. Each machine that you're going to see will have a screen with a dot or an indicator. Here's your gray dot here, and that correlates to this bump that's on the curvilinear probe here. So that lets you know which direction the probe is facing. For standardization, we always have the bump on the probe and the dot facing towards the patient's head whenever we can, or towards their right side. When you look at cross-sectional anatomy, there are basically three slices of anatomy that you're going to visualize with the ultrasound beam. The transverse, or the short axis, so this one cutting the person basically in half, like if they were in one of those big saw boxes that you see at the circus when they pretend to cut people in half. That's the transverse orientation. That's probably the most common view that you'll see us do in the emergency department. Again, remember that the probe, that tab, is going to be pointed towards the patient's right side. The sagittal, or the long axis, so if you look like you cut someone in half so that they would have a mirror image on either side of their body, So long axis, the indicator would be pointing up towards the patient's head, just like the med flight doctor is doing here in the helicopter. So the probe indicator is up towards their head. This is a sagittal view of that person. And then the coronal axis is when you scan from the side of the patient. So this would be like we do with a FAST exam. So we're cutting them in half, both front to back, cut in half. And this is the coronal scan. That's what we were looking at with that last one with the liver and the kidney in the right abdomen. And we're going to take a look at that one again here. So again, shooting your beam through the patient here laterally in the coronal plane. This is the curvilinear probe. We've got the dot here again and the dot on the screen heading up towards the patient's head. And what we're doing is we're looking at their liver and their kidney right there. And again, just to reiterate here, you can see the dot is in the top left-hand corner of the screen. That correlates with the bump on the probe, and that's always going to be towards the patient's head. For this orientation, again, just so you know what you're looking at, the probe is up here at the top where it says superficial. So this would be the skin that you're shooting through, the subcutaneous fat. Then you get to the liver. And the further you go down is the deeper into the body that you're looking, okay? To the left side is going to be towards the head of the person, and to the right is towards their feet. You may hear some different terms regarding this. So instead of towards the head and towards the feet, you may hear it referred to as the leading edge and the receding edge. And then the superficial portion of the view is called the near field. And then the deeper you're penetrating into the body, obviously that would be the far field. So echogenicity is basically the term that describes how tissues look on ultrasound. So the four terms that I want you to know here, there's anechoic, hyperechoic, hypoechoic, and isoechoic. None of these have anything to do with the Amazon device, but I don't know. It kind of made me think of the echoes when I was working on this presentation. So anechoic, the term means without echoes, and those structures will look completely black on the screen. This is typically done when you shoot an ultrasound through ascites, blood, or urine, for example, through the body. The reason for that is the sound waves that are generated by the probe are able to easily go through urine, blood, ascites fluid, and there's not a whole lot to reflect them back. So they just keep going, and those areas look like they're empty because there's nothing to really bounce back the ultrasound waves. Hyperechoic is the term used to describe when there's a lot of echoes that are coming back frequently. These structures are going to look really bright white on the screen, and the great examples of those are bone, tendon. The diaphragm looks very hyperechoic. You can see in this picture down here on the right, what we're actually looking at is a rib fracture. But you can imagine the ultrasound waves as they come superficial towards deep. Basically, they're hitting that bone and they're bouncing back because there's a solid structure there. Hypoechoic is a term that means that there are less echoes. So things like solid organs that have a lot of water or fluid in them, such as the liver, which is here. So you can see it's kind of that darker gray color. It looks fairly consistent going through it, but that will be described as hypoechoic. And then the last would be an isoechoic structure that has relatively the same amount of echoes going through it. So the kidney and the liver here are really about the same echogenicity, so they probably would be described as being isoechoic to each other. So again, this is an ultrasound picture of a urinary bladder. And what we're showing basically are three things here. So the bladder here is obviously full of urine. It looks absolutely pitch black, like there's nothing in it. That's because, again, those sound waves there's nothing to really reflect them back. They transmit very easily through fluid, so it looks dark. The back wall of the bladder is made out of solid tissue, so that does reflect back quickly, and that gives you that bright white line. And then the hypoechoic is really kind of this gray area here, or less dense. Resolution obviously is going to be important. We talk about resolution when we talk about cameras, and it's the same principle that really applies to the ultrasound probes. It's the ability to discern two discrete items when they are present, or basically it's another term to talk about how crisp an item looks on ultrasound. It is dependent on the frequency of the probe. So in general, the higher the frequency of the probe, the better the resolution is. So the obvious question always is, why don't we just have all high frequency probes all the time for good resolution? Well, the problem, again, like we were talking about before, the high frequency probe beams become more attenuated at certain distances when they're limited in the depth that they can give the high frequency probes. So I just dropped a term called attenuation. What is attenuation, you might be asking? So attenuation is one of the things that happens to the beam that weakens it after it comes out of the ultrasound probe and goes into the body. So there's attenuation, absorption, reflection, scattering, refraction, and diffraction. And each of these pictures sort of shows that in one way or another. So you can imagine, just like everything else, the ultrasound probe is putting out a sound wave and it's trying to bounce it back so that it can listen for different echoes from the tissues. If you don't get a straight on shot in, some of those sound waves will bounce off at a unexpected angle, and so you'll get refraction. Dispersion is when you have a round object and the echo doesn't come directly back to the probe, it scatters in different directions. Absorption is obviously the further the sound wave has to go into the tissue, the less strong it becomes as it gets down there. And then divergence is just those waves spreading out in that fan-like form. The ultrasound beam does become weaker as it passes through the tissue, and the energy from the wave is absorbed by the tissue, which can lead to some heat being generated in those tissues. Each probe has a different setting that determines how much energy is released, and attenuation is absorption due to the medium it's traveling through. Here you can see that the tissues are variable in how much attenuation they cause. Obviously, water here is the friend of ultrasound, right? So it has the least attenuation here. Bone and teeth are going to have the most attenuation, so they will absorb the most of the ultrasound wave. One way to correct for attenuation is with what's called gain. So gain is kind of like an amplifier. It can also be thought of as like turning up the exposure in an underexposed picture. It's going to increase the signal of the ultrasound beam. And it's helpful, it would be helpful in the picture to the left. So we don't have enough signal coming out of that beam. So it would be good to turn it up because then you can see what some of those structures look like. In the picture on the left, though, it's overdone, it's overexposed. And this is a picture of a urinary bladder. So that bladder right in the middle here should be nice and crisp and black, but because the gain is turned up too high, it all kind of looks washed out and white. The risk of using too much gain is that it decreases the amount of grayscale that's available, and thus it makes the image more difficult to assess. And we know that for certain tissue, attenuation of the ultrasound wave, it attenuates more than others and weakens it. The opposite is also true. So for ultrasound traveling through water or something that is low attenuation, the beam is stronger compared to the beam that has to travel through other tissue. And this leads to what's called posterior enhancement. So it looks brighter just based on how the beam and the attenuation work, not because that there's anything wrong or pathology. So the example here, the two red arrows, the density of the tissue that they're both pointing to is exactly the same. But because the ultrasound wave that made it to this arrow and then traveled back had to go through more dense tissue than the one that went through the urinary bladder and back, this all looks lighter gray than this does back here. This is a very normal phenomenon. It's something that we see all the time. Another adjustment that you should make to the ultrasound is the depth, or how deep the beam goes into the body. There is a sweet spot for how much depth you need to have to get a good view of what you're looking at. Basically, the rule of thumb is that about 2/3 or halfway down on the screen should be the object that you're looking at. If you go too far down, you can't really see what you're looking at, but too little depth, you won't get a good full picture of anything that's behind it. It seems self-explanatory until you start scanning and get caught up with what you're seeing, and you lose sight of how to optimize the view. As you can see for both of these two pictures, there's a lot of gray in here, and by changing the depth for either one of these, you could get a much better view. So this picture on the left here, again, we're looking at a liver, and we've got a kidney here. But because we are shooting way deeper into the tissue than we need to, the rest of it gets washed out. This picture here on the right is, again, a urinary bladder, but you barely get the backside of the bladder, so it's hard to say if there's any free fluid behind it, and that's what we're actually looking for. So for the picture on the right, we should increase the depth of the beam so that that bladder comes up higher in the screen. For the picture on the left, we should decrease the depth so that the kidney and the liver are about 2/3 of the screen there. You may hear about some other terms in ultrasound. There's different modes for the ultrasound. B mode is the most common one. This is most of the pictures that we make in a general scanning mode. The Doppler is used to measure the direction or flow of something. This is the one where you can get actually pulsatile waveforms. This is when we're trying to look for arterial versus venous blood flow. Occasionally they'll use this when they are assessing a fetus for heartbeats. And then the third one is something called M mode. So M mode is kind of an interesting one because it takes basically an ice pick view through the structure, and then it spreads it out through time, and you can look at how things move. So for this example here, the M mode, we have taken, just imagine this little slice here gets drawn out linearly in time. And what you're looking at here are the valves of the heart that are opening and closing with each heartbeat. And you could imagine with your mind's eye, these valves are going to open and close and go up and down, and that's what's being drawn out over time here. So how could ultrasound be used in the pre-hospital world? This is why we're all here, right? This is the whole reason we're here for this talk. I'm not sure exactly what's going on in this picture. They're doing a subxiphoid view of this gentleman's heart. He looks pretty comfortable, though. I'm guessing they're probably trying to figure out if he's got a big pericardial effusion or something that they can act on. So the long and the short of it is that the 20 years of using ultrasound in the emergency department sounds like a long time in some ways, but in a lot of ways, it's really still a new tool that's evolving quickly. And the same is true for out-of-hospital applications. So there are a lot of aggressive medical directors and services who are using field ultrasound. But because it's still an evolving tool, there's not a whole lot of published literature on it right now. One of the things that people really need to decide is how feasible it is to get these probes. They're not cheap. The prices have been coming down. They are more affordable. They're more practical, but they're still, a pretty significant budget line item. And when you're in a service that is, strapped for cash like most municipalities are, trying to dive in and buy a $3,000 butterfly probe is a big purchase. And then the last thing to consider with a lot of the out-of-hospital point of care ultrasound really is what is the practical use of it or the scope. And a lot of that is still being determined and being defined. A lot of the literature that's out there at this time is really based off of the European models. Now they have a different way of running EMS and pre-hospital care there, but they're the first ones who are using ultrasound. I think that the compelling reasons to use ultrasound are really in cardiac arrest. You can use it for peripheral IV starts, and then sometimes you can use it in trauma to see if there is free fluid in the abdomen, if that's the reason that someone's becoming hypotensive for you after trauma. One of the suggested applications, like I was just mentioning, for pre-hospital ultrasound comes from the literature that we use for focused ultrasound to look for cardiac activity or to find intervenable causes for cardiac arrest in the field. So from a couple years ago now, but a pretty interesting article that was published in Resuscitation in 2016, emergency department point of care ultrasound in out of hospital and in ED cardiac arrest. This is a large multi-center prospective observational study. Patients with out-of-hospital cardiac arrest had ultrasound performed by physicians at the beginning of ACLS that was started in the emergency department, and then again at either the 5-minute mark or at the end of resuscitation. Even if people didn't have cardiac activity on the first ultrasound for the study, resuscitation had to continue for at least 5 more minutes to do that second ultrasound. And this chart pretty much shows what they found. I think the thing that's really interesting on this one is that of the patients with PEA, you can see about half of them did have some sort of cardiac activity on the bedside ultrasound. For those in asystole, the majority of those did not have any cardiac activity. But I think that this probably goes back to the hypothesis that a lot of us have, and that PEA isn't really PEA. It's just a really weak contraction, and you can't always palpate that pulse, but there is something there. So then they took a look at the patients who had cardiac activity. There was a much higher likelihood of ROSC and survival to admission and even survival to hospital discharge. But the thing that I think is important to keep in mind here, even those who didn't have cardiac activity on the bedside ultrasound, there were still patients that survived to ROSC and to admission. So this 0.6% who survived to discharge without cardiac activity on their initial ultrasound, there were 3 patients out of the 800 patients that they enrolled. So, but it's not 0. In this study, and now they were looking at non-traumatic cardiac arrest for these cases, they did find 13 patients, they found 34 patients who had a pericardial effusion, and they attempted a pericardiocentesis in 13 of these. So this was an intervenable cause of cardiac arrest that the ultrasound did make a difference on. In the patients who had the pericardiocentesis done during resuscitation, 2 of them survived to hospital discharge, so about 15%. Just as a reminder, pericardial effusion is when you get that big buildup of fluid in between the heart and the pericardial sac that impairs diastolic filling and reduces your cardiac output. This is one of the ones that can cause you to acutely arrest, and that can be relieved with a pericardiocentesis. Often we think about ultrasound being helpful in finding the reversible causes. There's really 2 main things you can find on ultrasound that could lead to an intervention being made in a cardiac arrest. One is tamponade physiology from a pericardial or a pleural effusion, or from a pneumothorax or a tension pneumothorax physiology. Both of these conditions, the tricky part of them, I wanted to show you some great pictures, but they're really, really rare conditions. The other thing about them too is that when you see them, you're pretty much taking action almost immediately, and the majority of people forget to save their clips in the moment, unfortunately. One of the other intervenable causes or things that we'll look for in somebody who's persistently hypotensive that ultrasound can be really helpful on is someone with a big triple A, so a big abdominal aortic aneurysm. We've got three places that we look at the aorta on the bedside ultrasound and see if they've got an enlarging aneurysm. Now, if it's ruptured, if they've got fluid in their abdomen, we'll be picking that up on their FAST exam as well. So another interesting paper to look at, again, from the Journal of Resuscitation, 2017, introduction of paramedic-led echo in life support into the pre-hospital environment. And this is the PUCA study. So this paper looked at paramedics who'd been trained to do cardiac ultrasound, looking for cardiac activity and cardiac arrest. This one was performed in Scotland, so maybe a little bit different structure than we've got here. They had a team of specialized paramedics who were dispatched to all out-of-hospital cardiac arrests, and they lead the resuscitation, and then this team was trained on cardiac ultrasound, and they did these ultrasounds at the scene. So the takeaway for this one and the paramedic-led ultrasounds, the paramedics got really good views. The downside to it, though, is that in their study, it took time for them to find the views that they needed, those subxiphoid views of the cardiac activity. And they really did notice that it increased their time off chest for pulse checks. So obviously we want to try and keep those breaks to 10 seconds or less. They were averaging probably 17 seconds or more. Other research done a few years ago also found that using ultrasound during pulse checks was the same in the emergency department environment. So when we are throwing those probes on and we're looking around, we end up slowing down or prolonging a lot of those breaks in the chest compressions. This is a study that was done at Maryland Shock Trauma. They actually had cameras that were installed in their resuscitation bays, and they found that when ultrasound was used, it extended their time for pulse checks too. They were even worse than the Scottish guys. They were up to about 21 seconds per pulse check break, whereas if they weren't doing point of care ultrasound, they were probably closer to 13 seconds. So the recommendations that really come out of those two studies, if we're going to use point of care ultrasound to help with resuscitation and terminating out of hospital cardiac arrest, the key is going to be finding your view while chest compressions are ongoing or the Lucas device is being used. One of the suggestions that was made was to potentially save the video clip during that 10-second break and then review it after you've restarted your chest compressions or restarted your Lucas device. Another suggestion that came out of it was to have a second person count down that 10-second break, and so it can hopefully help prevent the ultrasound operator from getting that tunnel vision. This is a pretty cool case of Dr. Haney Katab, who I was talking about earlier with the MedFlight Sono. He's one of our MedFlight docs. He's doing a field ultrasound on a patient's right chest. So again, for orientation, his right hand is up near the C collar. You can just see in the corner of the screen. He's looking for lung sliding and signs of a pneumothorax. Obviously, this is something that they would want to address before they got into the close quarters of a helicopter to begin their transport in this traumatically injured person. There's a lot of logistics to really consider when we bring ultrasound to the scene. All three of our MedFlight helicopters have handheld systems on them, but there's been a lot of struggles with being able to save the images consistently. We've had cords that have gotten broken. And even though the leadership has bought in and all of the docs really love it, it's hard to track down all of our providers so that we can do continuing education and training to keep their skills sharp. So trying to keep scene times down, we've been thoughtful about how ultrasound gets put into the protocols. The great thing, though, is I've got a couple wonderful clips that Dr. Damewood was able to pull from the MedFlight folks. So here is an adult patient that had a witnessed cardiac arrest. This image is the most common view done in cardiac arrest. This is the subxiphoid view, so right below the xiphoid process. The dot is pointed towards the person's right shoulder, and it's coming up through the liver and taking a look at the heart. So for orientation here, this is the phased array probe. The probe is right here. This is superficial tissue. Here's you're shooting through the liver, and then the structure that's beating back there is obviously the heart. Looking up into the chest, it allows compressions to be ongoing even with the Lucas in place. So again, remembering that black is fluid, such as blood on the ultrasound. You can see that there's blood inside the chambers of the heart, and you can also see that it's squeezing there. So again, just highlighting the 4 chambers, remembering your anatomy and what you go through. So the first thing that you'll hit going through the liver is that right ventricle. Sitting on top of that is the right atrium. Behind the right ventricle is the left ventricle, and then on top of that is the left atrium. And you can see, again, like I was saying, you've got good RV and LV squeeze. This heart is beating. Here's another case from MedFlight. This is a traumatic cardiac arrest on scene. There is no cardiac activity that is seen in this clip. It's actually harder to make out the heart when there isn't cardiac activity because your eye is automatically drawn to things that are moving. So this patient was called in the field knowing that it's not a perfect view, but it seems that survival here is going to be much less likely without any cardiac activity on the ultrasound. Here is another cardiac arrest patient who's got a subxiphoid view. The thing that you see here, there is some movement that happens on this one, but that's actually related to the ventilations that are being given to the patient. So this is where the clinical context really comes into play, knowing what's happening with that patient in real time while you're getting your images. Because if you didn't have that clinical information, you could be confused that there may be some cardiac motion here. Here's another example of a traumatic cardiac arrest from MedFlight. So this is a 6-year-old patient that had a traumatic cardiac arrest in the field. Initially, they did not see any cardiac activity. What you're looking at here, the movement is actually swirling of blood in the right ventricle. So it's just kind of sitting there and it's rolling around. But you can see left ventricle back here, there's no organized beat. The thing that was really fascinating about this case is that they slid up and did a pulmonary ultrasound, and they noticed that this patient had pneumothorax, or they were suspected for pneumothorax on their ultrasound. So they needle decompressed them, and afterwards did have return of cardiac activity there. And then here is the picture, basically the repeat ultrasound after they decompressed the chest. Now there is cardiac activity that you can see. They transported this patient to the AFCH for further treatment instead of calling it in the field. Sadly, this child did succumb to their injuries in the PICU, but they did survive to become an organ donor to 2 different families, and they were able to survive until their family was at the bedside to be with them when they passed. Another image taken from MedFlight. This was a scene response for a trauma patient. So this is that same right upper quadrant view that we had showed earlier, looking through the liver and the kidney. The thing that's important here, so reviewing your anatomy, the liver is the larger gray structure on the left, and then the kidney is the one that's behind it. The interface between the two, there's a bright shiny line there that's called Morrison's pouch. And this is one of the places where fluid can collect, especially for the person who is flat on their back, supine on the gurney or on the stretcher. We'll see blood collect there pretty quickly. You can see there is fluid in the image on the right, that black pocket of fluid between the liver and the kidney. The crew called this a positive fast exam, and they gave TXA, and they really did help set priorities for the trauma team when they received them for resuscitation. We already knew that they had bleeding in their abdomen. They were getting TXA and product. The trauma team was already making arrangements to go to the OR even before the patient arrived in the ED. And again, just highlighting that fluid here so you can see that dark black triangle there that's now got a red triangle in it. This is that potential space that fills up. The other thing that I think is really interesting, an interesting use of point of care ultrasound, is the ability to start peripheral IVs on patients who have difficult access. Excuse me. So for these pictures, obviously these are taken using a mannequin, and this is in practice, so there's a lot of artificiality to it. But you can see with that linear probe, the photo labeled B, you can watch the needle tip actually come down and enter the vessel, so you know that you get into it. C is the needle tip going into the back wall of the vessel, and then D is once the catheter has been slid over the top of that angio needle, and now you've got IV access. You can also, go looking for different veins and make decisions based on what size of catheter you can even put in them, and see how far they are from the surface to see if you've got enough distance. So top left picture here, big vessel, pretty superficial. They measured it out, and it's 0.29 centimeters, so it's big enough to get a regular 18 gauge IV in. The picture at the top right corner is 0.21 centimeters, so it's plenty big enough to get a 20 gauge IV, but the depth from the surface of the skin to the vessel is too deep to get access with a standard angiocath. Lower left-hand corner, tiny little blood vessel that's too small and too deep. But then the bottom right-hand corner, a nice size 0.25 centimeter vessel that'll easily take a 20 gauge IV, nice and superficial, that you might not be able to feel. So in conclusion, point of care ultrasound really is a very useful tool to provide limited information to some binary clinical questions, and it can help guide procedures as well. Understanding how the beam works and what you're looking at is not only important for the interpretation of the images, but it's also helpful when you're communicating to other people what you see and what you want to do. In the out-of-hospital cardiac arrest, ultrasound, I think, could provide really useful information for resuscitation. It's also really useful for trauma, and potentially could be great for ultrasound-guided IVs. And with that, that is the end of my slideshow. So again, I just wanted to say thank you to everyone for taking the time to listen. I hope that this was useful for you. And if you have any questions, please don't hesitate to reach out. Thank you.